Pericarditis. So pericarditis is the inflammation of the pericardium which surrounds the heart, and the diagnostic criteria include the chest pain, pericardial friction rub, ECG changes, and new widespread ST elevation or PR depression, and pericardial effusion. Two or above criteria are necessary for the diagnosis of pericarditis. Chest pain is usually fairly sudden, and it's over the anterior chest wall and sharp, and it decreases with leaning forward, and you can see corresponding changes in the ECG, which is usually global ST changes, which may normalize after some time, and chest X-ray is usually normal. The initial evaluation for such patients include history and physical examination, echocardiography, ECG, chest X-ray, testing for tuberculosis, ANA, HIV, blood cultures, and viral studies. And the diagnostic criteria include the fever and evidence of effusion or tamponade might be associated with it, and if there is a failure to respond to therapy, then we need to look for other options of management. So the treatment depends on the etiology. If it's a viral etiology or idiopathic, then we have to manage them symptomatically, give ibuprofen or ketorolac, and glucocorticoids may be tried in some conditions. So if we talk about the pericardial diseases, could be acute pericarditis, chronic relapsing pericarditis, constrictive pericarditis, cardiac tamponade, and low pressure tamponade, and a restrictive cardiomyopathy caused by these conditions. So pericardium is composed of serosal layer and fibrosal layer, and there is some pericardial fluid, and there are ligamentous attachment of the pericardium to sternum, vertebral column, and diaphragm. And as you know, we can open the pericardium in surgery, so it is not very essential, but it reduces the friction to cardiac movement and is barrier to infection and inflammation, and it can limit the cardiac displacement, and that can cause obviously the hemodynamic disturbances. The common causes of acute pericarditis is Coxsackie A and B virus, and which can also give rise to myocarditis. Other causes includes mumps, varicella zoster, influenza, and Epstein-Barr virus. Acute pericarditis could be non-infectious, could be associated with myocardial infarction. Uremia is one of the common cause, neoplastic diseases, radiation-induced, and connective tissue diseases, and could be drug-induced. Diagnostic clues is the history, sudden onset of anterior chest pain, physical examination, and there's three components: presence of rub, and as we discussed, the ECG. Acute pericarditis can give to chest pain, fever, tachycardia, dyspnea, and pericardial friction rub, and there's an abnormal ECG, and with sometimes ST elevation and later T wave changes. And there is a associated murmur associated with it. And as we have discussed, the viral pericarditis, it could lead to the complication of myocarditis and recurrence of tamponade, and we have to treat the underlying disorder. We have to treat this condition with NSAIDs, and corticosteroid could give to symptomatic relief. Chronic relapsing pericarditis occurs in a small percentage of patients, and pericardectomy for symptomatic relief is not always effective, and we can use non-steroidals. So essentially the management remains the same for acute and chronic diseases. Dressler syndrome is seen typically after the myocardial infarction and treated with low-dose aspirin. The differential diagnosis include MI, pulmonary embolism, pneumonia, and aortic dissection. There are 25% chances of having recurrence and 60% effective long-term if they are more effective if taken chronically, and fewer side effects than long-term steroids. So these conditions can also present with large pericardial effusion. In such condition, there is a soft hard sound, reduced intensity of the friction rub, and electrical alternance in ECG can be seen. And the ECG will be of low voltage, and you'll see the alternating amplitude of the QRS complex. So one can do chest X-ray and echocardiography to evaluate such conditions. The pathophysiology of pericardial tamponade is increased intrapericardial pressure, which exceeds the ventricular diastolic pressure, causing the impaired diastolic filling and elevated venous pressure, increased JVP, hepatomegaly, edema, decreased filling and decreased stroke volume, and reflex tachycardia and hypotension. So early stage, there is a mild to moderate elevation of CVP. Advanced stage, there is changes with the intracardiac pressure, ventricular filling, and decreased stroke volume, which leads to hypotension and impaired organ perfusion. Beck's Triad, you will see there is a decline in the systemic arterial pressure, elevation of the systemic venous pressure, and small quiet heart. Pulsus paradoxus is exaggerated, like more than 10 millimeters of mercury, decrease in systolic blood pressure during normal inspiration, and in inspiration there is an increased venous return, increased RV volume, interventricular shift towards the left side and decreased LV volume, and there is a decreased stroke volume, and systolic pressure falls. So the clinical features of the cardiac tamponade include dyspnea, fatigue, cough, agitation, restlessness, syncope, shock, and urea. And physical examination shows pulsus, paradoxus, tachycardia, increased JVP, and hypotension. And obviously, it can be recognized on echocardiography. And RA and RV walls are thin and relatively low intragravitatory pressure, so absence of compression virtually excludes the tamponade, and presence of compression is suggestive but not diagnostic. So when to treat pericardial effusion depends on the management, post-surgical patient or post-MI, so one has to consider different things. And if it is symptomatic, then a patient needs to be stabilized and treated. And it could be pericardiocentesis can be done by a surgical technique. It could be done percutaneously under echocardiographic or ultrasonographic guidance. Constrictive pericarditis, it's a fibrous thickening, and there are adhesions and calcification around the pericardium. Most common etiology is TB, or it could be idiopathic or post-pericarditis of any etiology. Constriction is a thickening of the pericardium that limits the diastolic volume and resultant syndrome mimicking that of right heart failure and difficult to separate from the restriction. So etiology include idiopathic 33%, post-pericarditis 18%, post-surgical 16%, radiation 14%, rheumatic 6%, infection 3%. So The clinical findings include fatigue, hypertension, tachycardia, elevated JVP, Cosmol sign, pericardial knock, and ascites and edema. So obviously you can see calcified pericardium, and imaging like CT, MRI, and cardiac cath can also highlight such constrictive pericarditis. In the echocardiography, you can see the thickened and adherent pericardium, respiratory bounds of the septum, diastolic mitral regurgitation, dilated IVC without respiratory variation, and normal E and a loss of A on tissue Doppler. So the treatment include the medical management and surgical management like pericardectomy, which has a high mortality and symptomatic improvement in 90% of the patient. So the mainstay of the pericarditis is like pericardectomy, and the surgical options should be considered in the patient who are symptomatic, and they will have a quick recovery after taking the calcification and the constriction out. Thank you.